Hello, everybody, and welcome to Angle Rounds for May. Today, we're going to hear a presentation called Brain Biomarkers of Chronic Pain. Are we there yet? By Paul Geha. But before I introduce him, I just wanted to run through the usual housekeeping items. Very importantly, all of your microphones and cameras are off, unlike a usual Zoom type of meeting. So only the presenters' mics and cameras will be on. And also make sure to not put messages in the chat box. We like to keep that for just the presenters or the panelists or the interpreters if any issues come up around the presentation. We hope that you have comments or questions for the discussion at the end. And if you do, please put those in the Q&A box at the, which will be on the bottom right of your screen. And when we get to the end, I'll read those questions to Paul, and we'll get through as many as we can. We'd like to get everybody's feedback for about the presentation. And at the end of the presentation, in the chat box at the very end of the session, there'll be a link that you can click on and fill out an evaluation. There'll also be a slide at the very end that'll come up that'll also have that link. And then tomorrow, an email will be sent out to everybody who attended today. So hopefully in one of those times you can provide some feedback. Okay, so now I'd like to introduce our speaker for today. It's Paul Geha from our own Department of Psychiatry. He's an assistant professor of psychiatry, as well as having appointments in neurology and neuroscience. Paul got his MD from the American University in Beirut, and then did a residency at Yale New Haven Hospital, and was then stayed at Yale until he came here about a little over 2 years ago. He's been doing really interesting work in chronic pain, looking at the biological mechanisms of that, especially with fMRI and brain imaging. Okay, so without any further delay, I'd like to introduce Dr. Geha, and I'll see you all at the end for a good discussion.
So thank you, Steve, for the kind introduction and for the invitation to give the George Engel Research Rounds. So I'm going to give you a bit of an overview about some of the work I've been doing and the state of the field when it comes to brain imaging in chronic pain and the development of biomarkers. So I have no conflict of interest. So as a lot of you here know, the burden of pain is very big in the US and in the world. For example, in the US only, the cost of pain per year is around $635 billion in direct and indirect cost. Chronic low back pain, which is a condition I'm gonna talk a lot about because I've studied a lot, for example, is the #1 cause of disability worldwide. And almost all adults, 85% of US adults, will at some point experience low back pain in their lives. And as we know also in psychiatry very well, that chronic pain is highly associated with risks for mood disorders, anxiety disorders, substance misuse, obesity, etc. And chronic low back pain was the #1 cause of opioid prescription in primary care settings for a long time, but now this is on a downward trend. And the treatments in general for chronic pain are unsatisfactory. For example, this is another problem associated with chronic pain. And for example, the number of deaths from opioid overdose climbed a lot in the past decade, and it was mostly driven by prescription opioids more than by, for example, drugs of abuse like heroin. So why biomarkers and why biomarkers in pain? But this is a general question in the field, not just of pain, but in psychiatry and lots of the fields that use brain imaging. Well, the question is very simple. To make rational decisions about diagnosis, about prognosis and treatment, and avoid trial and error approach. Because, for example, we know that in psychiatry, but also in chronic pain, a lot of the diagnosis we make is based on two main factors: the subjectivity of the symptom report. So patients will tell you, I have X amount of pain, and the expertise of the physician. So in both of these, you can tell that a lot of the subjectivity will come in, especially that the physician to date does not really have any quantitative test for chronic pain. And here on the right, I'm showing just an example of so many types of biomarkers that are being considered nowadays, not just based on imaging, but based on many other digital technologies. And this is a topic of hot research, especially in the industry, because there is a lot of market also for it. So what is a biomarker? Well, according to the FDA NIH biomarker working group, the definition is a characteristic that is measured as an indicator of normal biological processes or responses to an exposure or intervention, including therapeutic intervention. This can include molecular measures, histological measures, radiographic or physiologic measures. And biomarkers that we are very used to in medicine, for example, are simply, for example, serum creatinine for kidney function. This is a diagnostic marker that if it crosses a certain threshold, we start saying that the patient has acute kidney injury, for example. So it is, the diagnostic biomarkers are very important to identify disease. And the prognostic biomarkers, which are which help us basically predict outcome. Like, for example, BMI simply is a prognostic biomarker for metabolic diseases or body fat. Another measure, for example, in heart failure that is used for prognosis is natriuretic peptide, which actually, if it's increased, can predict death from congestive heart failure. So there are several types of biomarkers. I'm focusing on these two here because I'm going to show examples of them in our data. And of course, there is one obvious one is a treatment biomarker. So some measure that changes once you give a patient a drug. So Wu and Wager in 2015 published a commentary in Pain, basically outlining what are the good qualities or what are the qualities that we would like to see in a biomarker. And in this table, they talk about that the biomarker should be sensitive. So you should see positive results when there is signal, let's say if you have pain, and negative when there is no pain. So sensitivity and specificity. It should be interpretable. It means that it should have a mechanistic / neuroscientific meaning, right? So we need to understand what it implies if it is there or not. It should be deployable in the sense that it should be practical to use it. It should be relatively affordable. It should have a specific standardized way of measurement. For example, in our case, the standardized measures I'm going to talk about are the measurement of both signal and structure. And it should be generalizable and, or if you want, valid. So in a sense, if I repeat the test in other sites or in other scanners in my case, then I should obtain the same results. So these are the good qualities or the important qualities of a successful biomarker. And I'm going to show that some of the data we have and other people have published actually is starting to fulfill these criteria. And this is why we are probably closer to biomarkers development. Now, what are the challenges to the discovery? There are so many of them, but I'm going to talk about a few of them. When you talk about pain, what are the challenges? And I touched on that just in the beginning. about the subjectivity of clinical pain. So what I'm showing here are pain ratings from different types of chronic pain patients. So if you look this way on the horizontal axis, this is time. And imagine here there is a scale like this scale here, where patients are rating their pain over a period of 10 minutes. These were taken from experiments we did in the scanner, where patients were lying down and reporting the fluctuations of their pain. And as you can see, back pain is different from post-herpetic neuralgia, which is a form of neuropathic pain. And it's different from chronic pelvic pain. But what is clearly showing here is that chronic pain is subjective. It fluctuates. And there is a problem of the scale, right? So what is the top of the scale? Is 10 really what we should use? 10 for me might mean something else for somebody else. So the maximum pain is always a problem, and it's a problem in general in psychophysical measurements in psychology. The other question we have, and I highlighted the tissues before when I talked about serum creatinine. So you could measure creatinine in the serum, you can measure body fat, you can measure the natriuretic peptide in the blood. Which tissue do you use to measure a biomarker for pain? It's a problem. And there is a big debate about that. Do we look at the spine, for example, in back pain? Do we look at the muscles? Do we look at the joints? So, and I will show just the basic slide on anatomy that there is information coming to the brain from all these sites, and then a lot more sites as we go up from the spinal cord to the brain. So, but there is one important factor here, or obvious factor here, is that pain needs consciousness. We have to be awake in order to feel pain. So that means that at some point, we will need the brain in order to experience chronic pain. And of course, how do we query the brain? The tool I use is functional brain imaging. I mean, definitely it's not the only one. People use EEG, etc. But we have to, at some point, when we want to study chronic pain, because pain needs consciousness, we will have to query basically the brain, the awake brain. So what is pain from the brain's perspective? Also a very short, I would say, introduction. But before I do that, I'm going to just show you the measures that we use in general in imaging, just as a slide on the technique that we use in a functional MRI. So the functional measures basically look at the blood flow. So those colored map that you see here are ultimately the result of changes in blood flow in response to neuronal activity. So we don't really measure directly the neuronal activity with our signal, we measure it indirectly. And it depends on this ratio between oxygenated and deoxygenated blood that changes once there is a brain activity. So that once there is neuronal firing. So imagine there is a neuronal firing here before these curves start changing. This is how the oxygenated blood drops as blood flows into the area asking for energy, basically, after neuronal firing. And our signal depends on the ratio between oxygenated to deoxygenated blood in the brain. We can also derive structural measures, and this is just an example here. So we're looking at, for example, how from anatomical images, we can segment and get the volume or the shape of certain cortical and subcortical structures like the thalamus shown in green, the putamen shown in magenta, and subcortical structures like the amygdala and hippocampus, which I'm gonna talk about in my data. So like I said, the anatomy of nociception. So in addition to the big problem or the many types of tissue involved in pain, you have also a huge circuitry that is involved in pain. So you have The C fibers and the A delta fibers receiving nociceptive input, so input that activates the fibers that are important in pain perception. And so those fibers go into the dorsal root ganglia, into the spinal cord, and travel upwards into and synapse into many different areas in the brain. A lot of these areas do many things in life. They just are not really specific basically to pain. So as you can see, limbic areas like the amygdala and the medial prefrontal cortex areas involved in emotional processing, if you want, receive direct nociceptive input. So direct, if you want, pain information from the periphery, as well as accurate sensation areas like S1 and S2 and supplementary motor area receive also input from the periphery about pain. The slide just highlights that pain is basically nociceptive input to the brain goes everywhere. And one thing I'm going to talk about repeatedly is the limbic system, which is basically the system that in the brain that is involved in emotional learning and memory. But it's a huge system that starts in the brainstem, hypothalamus, thalamus, amygdala, hippocampus, ventral striatum, and cingulate cortex. And it's well known to receive input from the dopaminergic system in the brain. So it's very important in motivational learning. So as you can see that the picture gets quite complicated when we look at the circuitry involved in pain. Now, this is an example from epilepsy patients that were stimulated in the brain with electrodes to, if you want, see or to elicit pain. And out of thousands of stimulations in 164 epilepsy patients, only 1.4% of the stimulation, and only those stimulations in this area shown here in red, which is the medial part of the operculum or parietal lobe, elicited specifically pain. So in a sense, unlike the visual cortex, for example, there is no real cortex for pain. And this is in contrast to what you just saw before in the cartoon about the anatomy of pain. The nociceptive fibers go everywhere, but we don't know of any specific tissue or any specific cortex, if you want, that elicits pain only, except for those very, very few neurons situated in the insula and operculum. So what do we see, or how do we study acute pain in the brain? Just as a simple, the first step. So this is, for example, a activity map with based on bold signal that I just explained. So the activity in relation to neuronal firing. And this is a map taken from a meta-analysis of many, many studies on acute pain, showing how they overlap. And as, again, this is reminiscent of the cartoon I showed, and you can see that there are a lot of areas that are activated when a person is experiencing pain or acute pain in the scanner. This includes heat, pressure, laser pain, etc. And this is, for example, here a map that comes from one study showing heat pain in patients and in healthy controls. And they don't differ that much. So if you do repeat this experiment on the left in patients in pain, you give them an acute painful stimulation, you don't see much difference from the healthy control, which we show here in this study. So in this study, patients with back pain received a heat stimulation that was painful to the back, according to the time course that is shown here in black. And both the patients and the healthy also, and also we had the healthy control group, both the patients and the healthy rated their pain. And the thermal pain in the patients who have back pain, or the thermal pain and the healthy control, had very similar maps as shown here. And if you contrast those maps, you don't find much differences, especially like you don't find differences, for example, in sensory areas. And this was commented on in other studies where the idea of having a pain map in the brain or an acute pain matrix in the brain is not really specific, because those areas we see here on the left are also shown in other types of experiments. Another painful experiment here on top, if you do tactile stimulation to the periphery, so if you simply touch the skin, in auditory experiments, and in visual stimulation experiments. So just putting someone in the scanner, giving them a painful stimulation, and trying to say, okay, I found the pain map, is just not the case, and it's not straightforward, and actually was not very helpful to differentiate between patients and control. And acute pain, like I said, is different from the clinical pain. So, but this was a major advancement on that problem. And this was a paper, work done by Tor Wager's group. And basically what they did is that they did several experiments in the scanner that would, if you use a linear model, simple analysis, would look like pain and activation. But so they did painful stimulation, they did warmth, so heat without feeling pain. They showed subjects in the scanner slides about being rejected, so social rejection experiments, and friendly slides if you want. And instead of using a simple linear model analysis where they looked at on-off pain, they actually tried to learn from the data how to predict those responses. So the ratings of the subjects in the scanner. So they split the data in a machine learning method, and they learn from parts of the data and then try to predict other parts. So what you end up with is you end up with a map like this one that has different weights, and those weights will determine ultimately whether, will tell you ultimately whether you're feeling pain or you were receiving a warmth stimulus, or were you seeing slides of social rejection. And they showed that actually they could, in several of these areas, show that they can really differentiate between those types of responses. This was in healthy people, definitely. And this was differentiating between the sensory experiences. But that map doesn't really work very well when you apply it, for example, and try to differentiate between patients and control. So patients who have chronic pain and control, if both are receiving an acute painful stimulation. Which brings me back to the slide. So again, acute pain really is different from chronic pain. Again, this is the rating for different patients with pain. So these are 5 patients rating their pain. And this is several patients and control rating acute painful stimulation. Those two things are different, which entails that we need to really study specifically the patient's population itself in the scanner. And that's also obvious because we know that the patient population is different, really, not just from the fact that they suffer from pain, but they also suffer from depression and anxiety, like I said, and substance abuse. So their brain supposedly should be different, and the way they perceive pain should be different from the healthy population. And this is basically what we try to do. And I will try to summarize some of our recent findings, but this is a result of several years of cross-sectional studies. But I'm just gonna go over the most recent longitudinal study where we see if you want, the transformation of the plastic changes that are related to pain, and how could these be turned into biomarkers. So chronic pain structural biomarkers. This is a longitudinal study where we looked at subacute back pain patients. We scanned them. So we obtained if you want, the functional measure and the structural measure. We scanned them at baseline when back pain was still early. It was subacute between 6 to 12 weeks. And then we followed them after approximately 1 year, we scanned them again, and some of them turned persistent, so they became chronic patients. So at 6 to 12 weeks, they were not chronic yet. After 1 year, they're supposedly chronic. And so we had 16 patients who were chronic and 19 patients who actually recovered. And as I said, we measured certain behaviors, we took structural data and functional data. And in addition to those patients, we also scanned one cohort of chronic patients who were already chronic separately in a cross-sectional design. And so first, how we defined recovery and persistence. So the recovered patients basically showed a drop in their pain by more than 30% at 1 year. So this is the visual analog scale of their pain rating at baseline and the checkered bar after at follow-up in the recovered patients and in the persistent patients. As you can see, the persistent patient, the pain stays very similar, but the recovered patients, their pain drops significantly. And this was seen also on different measures of pain, like the McGill Pain Questionnaire, the Neuropathic Pain Scale, and the pain catastrophizing scales, which are different ways of assessing clinical pain. So the first thing we looked at was the structure in the brain. So we examined multiple different subcortical structures that are part of the limbic system, because this is based on what we knew from previous data where we suspected to see the changes. And so, for example, we found that subacute patients here in A, compared to healthy and back pain, are somewhere in the middle. Their volume of this area, the left accumbens, which is an area involved in decision-making, in turning our motivations into decisions, its volume is somewhere in between the chronic patients and the healthy. Now, when we split up the patients at baseline between recovered and persistent, so we could tell now at baseline after follow-up who became chronic and who recovered, so we can split them at baseline. We found actually that out of these here altogether, the people who really, or the group that really had the smaller accumbens or the smaller ventral striatum was the persistent patients. So patients at baseline who had the smallest accumbens compared to the healthy and the recovered were the ones who ultimately stayed in pain. And this volume didn't really change at follow-up. It stayed the same, whether in healthy, in the recovered patients, or in persistent patients. That suggests here that this area, and this measure, the volume of the accumbens, is a prognostic factor for pain. It predicts the persistence of pain based on its size. And we looked at other limbic structures, which were already actually found to predict chronic pain. So we found that the amygdala at baseline is smaller in the patients who persisted in having pain, which is shown here in red. So the volume of the amygdala, which is very important, for example, in learning about fear and associating fear with outcome. And so the amygdala really was smaller in the persistent patients, and the shape of the hippocampus shown here on the right side was also different. There was thinning in the patients who were persistent compared to the thinning of the structure compared to the recovered patients. These two findings actually in the amygdala and hippocampus replicate an earlier study by Vachon-Brissot et al., showing also that the amygdala and the hippocampus shape and volume actually, if you want, their structural properties predate the onset of pain. So they are smaller in the patients who persist. So this is their persistent patients compared to their recovered in gray. And this is the amygdala and this is the hippocampus. And the plot here is volume. And the interesting part that they had here is because they had the follow-up for more than we did for 3 years, they found also that really those volumes don't change that much with time. So these are, if you want, measures of vulnerability. They are static if you correct for age, but they don't change much in time, but they do predict outcome. And what they show here in G, for example, these are the shapes of the amygdala, showing also thinning in the patients who persisted in having pain at follow-up. So we did also collect data not just on volume, but on white matter, and we did a tract-based analysis, and this was done by Noah Lee, who's a student in my lab. I'm just gonna go through the steps quickly, and basically you collect your anatomical data, and then you collect a diffusion image, which is overlaid here in black, and the diffusion image will basically have high values in major highways in the brain, which are the white matter bundles. The major highways in the brain have increased water flow. Therefore, you can measure directionality of flow and have an idea about the anatomy of the white matter. And then with the protocol that we use, it's called tract-based spatial statistics. We only look at the center of these highways, if you want, by looking at the center of these bundles in the brain. And then using those measured in each subject, you can now start looking at different types of population. So what I'm showing here in the first red square on the left is the difference between, again, recovered patients and persistent patients. So this is, the map here is a contrast. The gray skeleton is just a skeleton of white matter all over the brain. It's like an average, if you want, across subjects. But the areas highlighted in blue to light blue are the areas showing differences in white matter properties locally in patients who recovered versus persistent patients. So this is just a contrast between recovered and persistent patients. So we found that the patients who have recovered at 1 year, at baseline, they had a higher FA value or a higher directionality of flow in the bundle called the superior longitudinal fasciculus in the brain. The interesting part is that the healthy control that we scanned at baseline, they were somewhere in between the recovered and the persistent. It means that, supposedly, it means that those healthy people here or subjects, they contain probably, or they have people who are both at risk for becoming chronic and resilient. So this is probably why this group of subject here is in between recovered and persistent. But the chronic pain patients were even, if you want, worse than the persistent patients. So but the interesting part is that we could find similar data from that other study I just showed before, where they also collected diffusion imaging. And we could look at this measure, only this area in the brain, in the other site, if you want, and classify their patients at baseline, because they collected this diffusion image at baseline and after 1 year at follow-up. And we could actually classify their patients based on the properties of this area in the brain as recovered or persistent. So that's what I'm showing here. And this is simply a receiver operator characteristic curve. And the way to interpret it is that the value in this area here, as long as it is to the left, where it can be highly sensitive and specific, since this is 1 minus specificity. So specificity increases as you go towards 0, and sensitivity increases as you go up on the curve. You can see that all these subjects from their data, if we use this measure, fall on the left side of the diagonal, making our measures specific and sensitive, or sensitive and specific. And it was so actually at visit 1. So when they studied their patients at baseline before they were chronic, and it was the same also at 1 year follow-up. So this is probably the first cross-site marker of resilience to pain, derived from structure of the right superior longitudinal fasciculus. I'm showing it here in actually a real specimen. This is the SLF here. And the SLF on the left side, this is here, the right SLF. On the left side, it's well known to be involved in language. On the right side, little is known about the superior longitudinal fasciculus. There is some data to suggest that it's involved in the perception of our own body, but I think there is work to be done as to why this bundle actually is involved in resilience to pain. It actually connects frontal areas here to parietal area. This is an example from our data from one subject showing the actual fibers using an approach developed by Dr. Zhang, our collaborator, and and analyzed by Kyle here, who is about to get his PhD in 2 days. So I think he's a PhD now. So the white matter bundle that comes between the inferior frontal gyrus and the parietal lobe is connected by the superior longitudinal fasciculus. And now we can actually study the geometry of this bundle and see how it differs between recovered and persistent patients. We started doing that. We are just analyzing the data. This is fresh from yesterday. But this is an example here from the paper by Dr. Zhang about the method showing, for example, how they studied a different bundle in the brain, the cingulum bundle, which we also intend to do because it's important in chronic pain. So we can characterize the geometry of these bundles and use that to understand risk and resilience to chronic pain. Also, what we can do is use these bundles to look at how different areas in the brain are connected based on an atlas. So we can convert the brain into different nodes and count the fibers that are going between nodes. And the fibers were derived, as I've shown before in the previous slide. And then we can compare groups. And here in the cartoon brain, what I'm showing is a difference in the number of fibers between the persistent and recovered patients. So this is a contrast, if you want, showing actually that the patients who were resilient had less connections, according to this method, less fibers coming out of a very similar area that we found using the other technique, coming out of the parietal cortex and going, for example, from the parietal cortex to the limbic brain in the medial prefrontal cortex. So this is a different way of getting the same result using two different techniques that ultimately are converging to show us the same difference between persistent and recovered patients. And both these measures, the measure of directionality that I've shown before and the measure, the fiber bundle measure, could ultimately become markers of long-term outcome in patients who are having a new episode of back pain. So what are the functional biomarkers that we worked on? So I talked a lot about the structural ones. I will talk about the functional ones. In that same data, we measured brain activity, but just a quick note about the technique that we used. We did analysis of frequency. Imagine this blue trace is the brain activity. There are basically two frequencies in this trace, if you want. There is the fast zigzagging signal that you see on top of the very slower, bigger, if you want, signal. And when you break this signal according to Fourier transformation into frequency domain, so you go from time domain to frequency domain, you'll end up with the two different peaks in the energy of each of these frequencies. You have the peak coming from the main frequency that you see here, and the smaller peak coming from the other faster frequency that you see in zigzag. So this is what we did. We broke the signal into different frequencies in the accumbens where we found volumetric changes. And we compared our healthy control to our chronic population first to see if this has changed. So we found loss of signal or loss of frequency in the short frequency, in the slow frequency band in this window. So inside the accumbens. So there is loss of energy within that frequency band in the patients that are chronic compared to the healthy. When we looked at baseline in the persistent and recovered patients doing the same analysis, actually, we didn't find any differences. So that looked like a marker of chronicity. And we actually confirmed that in the subsequent analysis. When we looked at the patients who persisted versus recovered at follow-up, so when the persistent became chronic, they started showing loss of frequency in that same area. So they didn't have it at baseline. It showed at follow-up 1 year, and it wasn't present in the recovered patients. And here is simply a plot between that frequency content and the pain, so showing an inverse relationship between the frequency content and the accumbens and the pain rating of these patients, the persistent in red and the recovered in blue. Now, the stronger part of this work was that we were able to get other data sets from other sites and reproduce, again, this finding in different patients with chronic pain and different healthy controls by contrasting them here, and found also this same thing that we found in our data in A here, we found it in E, in other data sets collected at two other different sites and with different scanners. So we highly suspect that this is actually a specific and highly reproducible signal for being in chronic pain. And actually here we also did, again, another classification based on new data from other sites showing that we could actually, based on that frequency content, we could classify recovered versus persistent or at follow-up, so when the persistent are chronic, and we could classify chronic versus healthy. Now, I want to emphasize that we were able to do these classification or able to separate patients despite having actually heterogeneous populations. So if we compare the 3 sites where we took the data, our sites in New Haven, to Cambridge and to Chicago, where the other sets originated, they had differences in age, they had differences in pain intensity, they had differences in duration of their low back pain, and even differences in their depression. So the strength of the finding is that it actually is invariant to other clinical parameters in these patients, and it shows no matter what, whether you are more or less depressed, whether you are older or not, etc. Others have looked at also markers of acute to chronic, like I said, a transition, and they found actually that the accumbens, again, connection to the medial prefrontal cortex, which is a link between 2 areas of the limbic brain that are involved in decision-making, especially value-based decision-making. Examples would include what am I gonna buy, what am I going to eat. So this connection between those 2 areas that they found that it actually is different between persistent patients and recovered patients, both at baseline and at follow-up. And they did a classification in a different data set where they showed actually that their measure is sensitive and can separate patients at risk. And by the way, this link here that I'm talking about is simply derived by taking activity in those 2 areas and correlating them, deriving a correlation. Of course, there are lots of pre-processing steps, but ultimately it's measuring the strength of correlation between 2 different areas. And something that we have been actively working on in our lab is reproducibility. Can we reproduce these findings now in different sites again? So we're collecting again data in the Rochester, on our current scanner and on the clinical scanner to actually measure and test the reproducibility and validity of our measures. So this is here the difference in frequency content, again, in the accumbens between healthy controls and chronic low back pain. And this is actually the link that was identified by the previous work between accumbens and medial prefrontal cortex in our own patients, showing there is a good reproducibility between sites and between scanners. And this is a work that my postdoc, Yeze, has been actively working on. And now actually she's trying to see, for example, if these measures are present, for example, in people who are depressed to see how specific they are. And we are trying to also investigate whether these measures, for example, are the same if you have knee arthritis or if you have trigeminal neuralgia, so different types of pain. So it seems that we are very close to identifying prognostic and diagnostic biomarkers. It seems that structure is a prognostic biomarker. I showed examples of subcortical volume, like the amygdala, the accumbens, and the hippocampus, volume and shape. I showed examples of white matter, and the diagnostic markers I showed was a functional marker taken from the BOLD activity. Now, of course, these are smaller studies still, despite the reproducibility across sites. We need to develop the technique more, and we need to do larger studies. And for example, there are many, many unanswered questions. I'll go through them quickly about these markers just because of time limitation. For example, one big question is, does it differ, do these markers differ by phenotype? I mentioned, for example, knee arthritis versus trigeminal neuralgia versus back pain. But what about if we look, for example, at within the back pain population, if patients have or do not have, for example, sciatica pain, because patients who have sciatica pain or neuropathic back pain, they do worse than people who don't have it. And actually, it's a more costly condition. So in a way, it could be a different, completely different phenotype. Would these patients have a different brain biomarker? We don't know yet, but we're working on it. I'm just gonna show an example again in the white matter. So far we're collecting this data. So far we collected 11 patients with what we call musculoskeletal back pain. So they don't have sciatica symptoms, 10 healthy subjects and 11 chronic neuropathic back pain patients suffering from sciatica. And we did the same analysis of white matter and examined group differences simply. And we found differences in white matter, so differences in the directionality of flow in the major bundle in the brain, the corona radiata, which actually carries fibers in and out of the cortex. This is preliminary, and we're starting to understand this data, but this is basically one of the next steps we are trying to understand when it comes to our biomarkers. We are trying to also understand important factors like age and sex, right? Because, for example, elderly patients have more severe pain, and they have, for example, back pain peak prevalence is in the 50s. This is a preliminary data analysis again here between, we subdivided our groups pooled across many, many sites between young and old, and we re-examined our diagnostic biomarker. And when we do so in this way, we do find a separation actually by age. We found that if you are younger, a younger patient around 20 to 30, you don't differ that much in that frequency content between healthy and control in this area and the accumbens, but the difference actually grows in the older patients whose average age was in the 50s. So the healthy are in green, and the patients are in red. And this is again our frequency content in the accumbens. And this is just a plot of how these groups differed in pain perception. So definitely the older patients had more pain. They had longer durations of pain. So this is the challenge of studying actually and comparing older and younger patients. But our measure of frequency was highly correlated to what they reported as far as pain. And we're trying to look at the effect of sex, so the differences between male and female patients. So far, we haven't found much. For example, this is preliminary data showing differences in a subcortical area that is typically sensory, like the thalamus. So we found, for example, like males who have back pain don't have a difference. Males and females who have back pain don't have a difference in volume in the thalamus, but females do. There are some differences in connections, but it's still unclear. We are trying to look at the effects of opioids. Just quickly here, people who are chronically medicated with opioids do not seem to have a change in the frequency content in that area that we found to be a signature of back pain. So patients who are chronically on opioids, they didn't, those groups here, so this is a contrast between patients on opioids and patients not on opioid. They had more pain actually than the patients who were not on opioids. But even if we correct for pain, we couldn't find changes in the signature of back pain. So being on opioid does not really correct, if you want, the signature in the brain. And as I said, we are trying to derive that for other conditions. Others are working on other types of chronic pain patients, as you can see here in different types of structural data. And we are actually also, and I'm going to touch on that quickly, trying to derive other types of biomarkers based not on the brain, but what the patient says, by breaking down patients' interviews into linguistic features, acoustic features, and facial expression. So this is in collaboration with Guillermo Secchi at IBM. Since again, patients rely on the subjective report of pain, and now there are techniques that can help us do automated measurement of pain, automated measurement of language from the content perspective, the structure perspective, from the acoustic perspective, and including facial expressions. So one of the experiments we are trying to do is to actually video and audio tape patients during an interview about their pain, break down the data into acoustic, speech, and facial data, and use that ultimately to classify different types of patients, to phenotype them, basically to come up with, again, a quantitative measure. And for that, we are planning to do patients with chronic pain, chronic low back pain, patients who have chronic low back pain but are receiving workers' comps, which are thought to be different actually from the patients who do not receive workers' comps, patients with knee osteoarthritis, and patients who have major depressive disorder, which is another chronic condition with a negative affect. And we are trying to also predict response to spinal cord stimulation in patients with intractable back pain using similar techniques. Those techniques, again, will be used in a machine learning model to ultimately identify correctly whether a patient is a back pain and knee arthritis, or whether a patient is a responder or a non-responder to treatment. So in conclusion, brain measures could become cost-effective measures for the diagnosis and prognosis of chronic pain, and surrogate targets for the development of novel analgesics. I didn't touch on that here. I just showed the result for opioids, but this is basically a step we want to take to see how effective treatment changes or not, or our biomarkers, or actually whether our biomarkers will predict response to treatment. Definitely biomarkers need further development around reproducibility, around precision. We need reliability studies, especially within scanners and across scanners. And of course, it seems that now we have other digital biomarkers that we can make use of in the clinic and use them for quantitative measures in our patients. And I would like to thank you all for listening and acknowledge a lot of the people who made that work possible. Thank you.
All right, thank you, Paul. So a lot of good data there and very interesting.
Thanks.
So we have some questions now. We don't have a lot of time, so we'll see what we can get to. The first question is from Brian Kane. Have you or others looked at resting state functional connectivity between brain regions associated with pain? And if so, to what extent, if any, are these functional connectomes diagnostic of chronic pain? With the additional point that brain volume measurements are affected by other factors such as hydration and stress. And do you think that these other confounds have been adequately controlled for in these types of studies you're presenting?
Okay, so for the first part of the question, yes, definitely. There are many, many studies on resting state. this actually connection that I showed between the accumbens and the medial prefrontal cortex in our data is taken from rest, and it is predictive of being, I mean, it is significantly different between patients and control. Others looked at large scale brain networks, and there's actually a recent paper by Torwager showing that they use these large scale brain connections in a machine learning paradigm to predict actually acute pain and clinical pain in healthy people and in chronic pain patients. So the answer is yes. Now, the other part of the question is the confounders of the structure. This is a very important question. Yes, there are effects from stress. There are effects from, let's say if we take, I don't know, hippocampal volume, for example, those measures could differ by stress or hydration, etc. So what we are trying to do is actually, we are trying to establish, like I said, how reliable they are. We're trying to include in our experiments, for example, other types of patients like depressed patients. And when we study our patients with pain, we actually make sure to have, if you want, a clean model. For example, most of the data I showed here comes from patients who are not really depressed. And so if that part of stress in that sense is not present, if you want, that would help basically prevent this confounder from affecting our data. But this is definitely an important factor always to keep in mind, and actually to come up with different measures that might be invariable to these confounders.
All right. Well, with that, unfortunately, we don't have time for any other questions.
Sorry.
I may email you some. Okay. But okay. Well, thank you again, though. This was good, and you're doing a lot of great work, and I look forward to seeing an update on this maybe in a couple of years.
Thank you for inviting me again.
Yeah. All right, so thank you, everybody. And we have one more Angle Rounds presentation this year. It'll be next month, and hope everybody has a good day. Take care.